the vast majority of people are not going to become seriously ill by this. So why are we taking this so seriously as a community? Why are we locking down our economy? Why are we ruining America? You know, what's that? Explain from flattening the curve of why this has been important and maybe the challenges of getting the messages out of how we so vastly need to curtail some things.
Yeah, so I think if you look at the various different models, predictive models out there, and the University of Pennsylvania has a model called the CHIME UPenn CHIME model. The University of Michigan School of Public Health has a model out there. And it's just talking about the exponential growth in infected patients, including asymptomatic patients. That somewhere between, we got about 330 million Americans, there's some models that say 25 to 35 million of us, 10% or so, might get this virus. And of those that get this virus, somewhere in the 5 to 8 to 10% may develop more severe illness with this. Mm-hmm. It's very clear that if it stays in the upper respiratory tract, where you have a fever, cough, things of that nature, versus the lower respiratory tract where you might develop more shortness of breath, it starts to get deeper in the lungs, the outcomes there start to diverge, meaning the upper respiratory tract tends to have very mild symptoms. The more lower respiratory tract with now shortness of breath and inability to breathe as effectively, that impacts people very differently. And I think the flattening the curve is really a strategy around trying to reduce the number of new cases. And we don't know who's going to be severe, who's not going to have, who's going to get severe.
Well, we're seeing a little bit more of that with younger people, some of them requiring care that didn't really think would be as severe. So really the individual to individual, it's a little harder to predict. I think the at-risk populations are still traditionally at risk, older people, just people with other, of any age who have some other complicating factor that would be agitated by COVID-19. They're at a special risk. But yeah, you don't really know. I think that's one of the challenges is you don't really know exactly if I get this, if I'm going to require hospitalization or not.
Yeah, so I think, the health system is really the if you need a breathing machine to be on a ventilator to support your breathing because of this severe inflammatory response in your lungs. And if you have 10% of the population infected and some fraction of that's going to need this type of care, just on orders of magnitude, to have so many people potentially needing this type of care at nearly the same time creates this fear, frankly, in my eyes and in my gut about how could we care for all those people simultaneously, possibly at once.
Sure.
It's frightening. And I think that's what's got everybody that truly knows about pandemics and our healthcare, our physicians, nurses, et cetera, really concerned, is that the system isn't designed for so many people to simultaneously have to need this type of care at the same time.
Yeah. Well, and the other complicating factor is that why we do need to keep it, I think, more serious is that there's a lot of people that need hospitalizations every day that are completely unrelated to COVID-19. They're already part of the system or they're a part of the inflow and outflow of patient care through any hospital system. But say I come in with elevated heart rate and I might be having a heart attack or some other chest pain. If your staff is already overwhelmed with COVID-19 patients and that tax the system, I mean, that system of having maybe a mild heart attack might actually have an outcome much worse than it would have under normal circumstances.
So thank you for asking that question, because I think that's a great point. 90% of us aren't going to really get this, and it's not going to be an issue for us, presumably. Mm-hmm. That does not mean that we don't have the other ailments that we normally have, because those are things that happen. And a heart attack's a great example. And I think what I'm worried about as a healthcare leader and a physician is, will our standard of care have to change for the worse, right? Mm-hmm. Because of this prioritization piece that we have to do, or that we have limited healthcare resources to devote to all the different people that need us at the same time. I mean, might you not have a real ICU nurse taking care of you in the ICU? I mean, that's possible. Would you have a there's not enough intensive care physicians around to manage that surge in patients, right? So that makes me very, very uncomfortable, Brian, and that's one thing that really keeps me up at night. We've had to make some really uncomfortable calls, and you mentioned earlier how things are so rapidly evolving. I mean, last Thursday, which seems like a long time ago because it's 7 days later now, but I woke up and was just checking through my messages and just looking at the news, and I always check some of the medical. I love to read about medical history, medical journals, and things of that nature, and just because it became very worrisome signals how cases went from 50 to 1,000, and seemingly very quickly, right? And so I began to feel like we need to prioritize now. We need to keep people healthy now. We need to think about delivering care differently now, and we need to shut or pivot or 180 now. So I gave my team the directive of, look, we have 18 clinics sprinkled throughout the community in a number of different locations, and I said we need to stop seeing patients face to face, right? And to keep that in perspective, we do about almost 2,300 visits each business day across all those areas face to face.
Yeah.
So to turn that off was
major impact.
Yeah, like a major adverse impact,
Sure.
frankly, right?
Yeah.
And
just from a business standpoint, but also for the community.
Yeah.
They're used to going in and seeing their doctor.
Yeah,
and
then for the 160 physicians or so, they're used to coming to their clinic and seeing their 15, 20, how many ever patients they see. So this is a very different thing, and I had to tell them, we're going to wind down face-to-face visits as of whatever this Friday. Report to your normal clinic on Monday. You're going to get education on how to do a telephone visit, okay, as a bridge, and then you're going to do video visits 3 or 4 days later, right? And everyone's going to do this at the same time.
Yeah.
so everyone was on this WebEx. A bunch of doctors and nurse practitioners and et cetera on this WebEx learning how to do these types of visits, right? Because they had less things to do because it wasn't safe to see the patients face to face. And I think, so that we had to pivot within a matter of days. And these are workflows normally that take months to perfect.
Yeah.
Right.
It was a major organizational change in how you.
And there's a technology integration piece that's not simple.
Yeah.
And and then some of these physicians and APPs ultimately will be delivering this care in the safety of their own home.
Yeah.
Right. So that's another thing with their care team, the people they're used to bumping into and say, hey, can you help me with this or that? They're not going to have that. So So it was a big organizational lift. So that's one thing we did. We turned off the face to face. We turned on telephone and virtual video visits on a dime. We prioritized some of our clinics to be the sick patient clinics, so where we could see patients with respiratory syndrome, right? We really think it's important to protect the hospital, right? You can't say going to the ER is not the answer right now.
Yeah.
We really got to keep that place is for those people that only really need to be there. And the ER could get very easily overwhelmed. So that's one thing we did, open up the sick clinics. Yeah. And then the last thing I think that's really important that we did is we started to think about our pools of predominantly ambulatory physicians historically that could help in the hospital if necessary. And that's for the nurse practitioners, PAs, and the physicians. So we have physicians that are trained as internal medicine physicians and maybe haven't done as much hospital medicine in the last few years because they've been more outpatient focused, but sort of on a volunteer basis say, if you guys need me, we'll back up our hospitalists. Yeah. Our pulmonologists are saying, because a lot of them trained as critical care physicians, they're saying, hey, we're on deck to back up our intensivists. Yeah. We know unfortunately, healthcare workers are going to get exposed. Some of them might develop symptoms of the disease, and then they have to have some sort of self-quarantine process, so that team would be out for a bit. Yeah. And I just hate to read those stories of emergency room physicians or intensive care physicians get this from patients, and then,
Well, we're seeing that already in New York and other, markets like, as you mentioned, Seattle and San Francisco. I mean, it happens quickly in the domino effect. Compared to the east side of the state, West Michigan's been fairly lucky, at least to this time stamp, of not having as many cases. But is COVID-19 here? Have you worked on patients at Metro Health with this official condition?
Yes, COVID-19 is in West Michigan. it's been in our hospital. We had our first confirmed diagnosed case fairly recently within the last few days. We have several more patients that are presumed COVID-19 positive patients, and they're in all the precaution areas of the hospital, special rooms, things of that nature, respiratory droplet precautions, personal protective equipment to take care of those patients. So, yeah, it's here, whether you're a big system or a small system or a medium-sized system, it's absolutely here. I'm kind of telling my family and my team that we probably need to assume 1 in 8, 1 in 10 of us has recently been infected. And part of the challenge with this disease is that there are so many mild or not symptomatic patients that when you don't have symptoms, you don't know what to do. So you're doing what you do, and
you're not going to modify if you feel healthy.
Yeah, it's like, and I think Kevin Durant's story kind of comes to mind. He got it, from maybe a game or a fan or something, but he's like, I had nothing, and if someone just didn't test me, I wouldn't have known. I would have been doing what I normally do. I mean, I would have sheltered in place because I'm in New York. I get that, or New Jersey, but it's just, that makes it tricky. And I think one of the things that's really challenging for America right now, and Michigan in particular as well, is there's some rationing kind of going on here, right?
Yeah.
We don't have 300 million testing kits, right? We have a fraction of that. And then also the personal...
How does that impact you? I mean, I know we should be testing a lot more, right?
Yeah, so I think the science suggests we probably don't need to do that, but I think there's a irrationality, there's a panic, there's I want to protect my mother and my father. For children, this is a non-issue for the vast majority of them. Men seem to be preferentially hit with this compared to women. That's some new data that's come out of China, verified by Italy and Japan and South Korea. So I do think if we could, in order to allay fear, I think there's a couple things that probably would be done in a totally perfect utopic scenario, and that is that we would have anyone that thought they needed a test can get it. I think that's one thing. And then the appropriate isolation/treatment or observation would be done for those people. And then 2 is, personal protective equipment. If you think for whatever reason when you go to the grocery store you need a mask, okay, have it. Now there's a science that says, look, maybe this isn't necessary. It's most important for those that actually have symptoms and coughing to mask so that they don't have these respiratory droplets that get other people sick. Yeah. But we're in this sort of irrational time.
I just want to bring up another point about testing kits before we move on. It's just that because we've been under testing in the United States, or not able to test as many people as need to be tested, is that the numbers of confirmed cases seem to be a lot less than probably what we have. And the ramifications on public behavior, because the curve is spiking like crazy given the tests that we have completed. The number of cases is rising exponentially. So getting the public's attention in the thing where we're also not confirming cases at a rate that as a health official are out there. This is exasperating a lot of communication problems.
Yeah, absolutely. I mean, you can take the number of COVID-19 positive tested patients and multiply that by some factor of 20 to 50 infected. So if you say there's 30,000 people here infected or 20,000 people in this state, or if you say there's 200,000 people in the United States, multiply that by a bigger number. Yeah, and that's probably how many true cases there might be out there.
Yeah, and this is and I don't want to belabor the point, but this is the challenge about social media in these days and just news organizations and health organizations to get that out about how serious it is. If you look at the data, that's one thing, but I think what you're saying is so powerful in terms of that it's somewhat chilling in the fact that we've tested who we've tested, they've come back positive. The factor of people who are untested that you can just project with science and math that are infected is exponentially higher.
Orders of magnitude larger, yep.
So we need to be sheltering and doing things, because if we really had some magic wand and we could test everybody right now, we would be blown away by how many people have COVID-19. Is that a fair statement?
Yeah, absolutely. I mean, could that be Could that be 800,000 people in the state, 500,000 people in the state, a state of 10 million people?
Yeah. You're just talking about Michigan.
I'm talking about the state of Michigan where I live. But yeah, I mean, but then you magnify that across the whole country, right? 330 million people.
Yeah, we're talking 20, 30 million people.
It could be that, yeah.
Well, it's chilling, but it's also it's an opportunity. So there is hope. We can all continue to be vigilant about sheltering in place and minimizing our contact with people.
Absolutely, cleaning surfaces. Might be prudent to wear gloves when you're handling an Amazon box or things of that nature. I think
we just started spraying at home with disinfectant, just spraying with the antibacterial packages, our mail.
Yeah, soap, water, I think bleach and dilution, not mixed with other cleaners is probably a good idea. Hydrogen peroxide works well. Vinegar, we think, doesn't work as well to disinfect coronavirus surfaces.
Okay.
Just throwing that out there for the
It is such an odd thing to do, just as a family, to go, okay, I'm going to spray this package down. It's a huge behavior modification because you don't really, I find that I'm just speaking personally, like you're like, oh, is this really something I need to do and take serious? Or like that package probably isn't infected, who knows? I think the point I'm trying to orient my behavior around is just behave more as if you have it and you're asymptomatic, and pretend that package was handled by somebody who was infected. I'll keep my family safer, but it is a hard pivot as a person and our human behavior to take it that seriously.
Yeah, and you're taking it like me as a medical professional. I'm taking it that seriously as well, and it's lots of changes in workflow.
Yeah.
For sure, and it's not an easy thing to pivot to.
Yeah.
But I think, and I know a little bit about your family, but I think those are all the right steps I'd take if I had family members like you do.
Sure.
And I think it's just abundance of precaution is what's needed right now. One of the things I think's just really important, Brian, for the viewers and listeners to be aware of is that some of these models are saying this could last more than a few weeks. Let's just put it that way. Could it be through the spring season? Could it be through a component of the summer season? In my mind, I'm kind of telling my people that that's very, very possible. And so, and the shelter in place thing could be going for a while. I get a little nervous when I hear people want to turn the economy back on by April or whatever day, Easter.
Sure.
That makes me a little uncomfortable, and I get why people want to do that.
To just go back to what we were talking about, I mean, the science points that it's not going to be done in April and Easter. It's magical thinking to think that. I think it's dangerous, and it's not about politics. It's about messaging and facts, and the science isn't supporting that. I think Dr. Fauci, who is someone who's, I think, become very credible and is credible well before he was in the role he has now today. These are the voices that should be the loudest in terms of not exasperating, because we can turn the economy back on, but if we're right back where we started in May 15 versus April, whatever Easter is this year, it's going to be worse.
Yeah, so
the outcome's going to be worse to the economy, which is everyone else is trying to protect so desperately right now.
I think the message should be that if we do, like all these governors have already done, and we do that for, I don't know if it's 90 days or if it's 120 days, and we tell businesses it's going to really be bad for 90 or 120 days. But if we do this now, we can decrease cluster outbreaks of this stuff kind of cyclically coming in and back, right?
Yeah.
Which is, you just got to really tamp it down hard. You got to hit it hard, and that means we have to be away from each other in business, in restaurants, and things like that.
Well, and the hard part is, and I didn't mean to interrupt, but I just want to amplify it, as that not everybody in the country is in the same point with this infection rate. So New York is one thing. We saw Governor Cuomo talking, very specifically about they're in the fight right now. They're in it, and it's coming to maybe to West Michigan in a week or two in that way. It could be coming to Indianapolis and Chicago, but we're all on a little different timing in terms of how this the symptoms and the severe illnesses present themselves.
So,
and the surge is coming.
Yeah, so that's a great insight. And I will say that in China, the Hubei province, they really locked down about 110, 120 million people with intensive tracking and things of that nature. They imported or exported, the rest of China exported about 40,000 medical professionals to that province, which doubled their medical providers in that province. I think a similar scenario might play out here in the United States, where you have rural, smaller states. I grew up in New Mexico, which is quite rural, and Albuquerque is one of the more densely populated parts of that state, but they may not be as severely impacted by this. They will get some, for sure.
Sure.
But New Mexico might export their intensivists, their respirators, and other things to harder hit regions, right?
Meeting real-time demand.
Yeah, exactly. So I think we will probably see that as this plays out over the weeks and months ahead.
What about the argument, if you could speak to that, maybe the cure is worse than the disease in terms of how we're all modifying? I mean, can you just be candid about what you think about that? Just saying, well, certain number of people die from stuff, all of different things every year: heart disease, diabetes, the flu. Just let this run its course, and survival of the fittest is kind of how we should approach this.
Yeah, I mean, I would just in those their patients, like my parents and and many other grandparents out there. I just think that's a little bit of a hollow argument in my mind. The difference here is, and we can argue that some of those things you mentioned are modifiable, potentially preventable, but they're somewhat harder to prevent because it requires real prolonged lifestyle change, committing to exercise and eating green, healthy foods and things of that nature, right? But this does have, I just feel like the sacrifice that we're asked to make for our fellow human being is something we just got to do, because otherwise lots of Americans, lots of people in the world are just going to senselessly die when we could have potentially just turned off our economy for a little bit and saved 1 million people. That's got to be worth something, right? And
it has to. And the other thing I don't like about this argument about maybe car accidents or heart disease or hypertension, and people die of all kinds of medical ailments. If I eat too many cheeseburgers, I can't infect you with my, and trust me, I eat too many cheeseburgers. That's not the point. The point is, COVID-19, I can infect you with my behavior. So that's creating I don't know if victim's the right word, but you're definitely been violently impacted by my behavior if I didn't modify it.
Yeah.
And that's a different type of disease that's preventable, because we can just prevent it by not having the contact that creates the transmission.
Yeah.
And it's different than saying, I need to eat more healthily and greens and it's different.
Great point. And I think absolutely that this, by locking down, that we can decrease the transmission of this disease.
Well, I loved what you said about it being a hollow argument, because my dander's been up. I've been a little frustrated with that consistent narrative, and if I can use, if this podcast, and if I get at all frustrated about communicating something, is that type of thinking is deadly to a huge part of the population, in that it's so hollow and insular, because you're not arguing apples to apples.
Right.
It's not even relevant, and it's not even an argument that makes any sense from a scientific perspective.
Yes.
I understand people die of the flu every year. That's despite a lot of things that we provide in a capitalistic society, free flu shots.
Yeah.
How serious is something, Dr. Pai, that you can get something for free in this country?
Yeah.
As a capitalistic society.
Yeah.
And despite every doctor visit I ever have, they tell you to get a flu shot.
Yep.
Every time I take my kids to the doctor,
Yeah.
get a flu shot.
Yep.
And despite that, you can go to Meijer and Metro Health and all these places to get free flu stuff. And despite that, 30,000 people still die and won't get the flu shot.
Yeah. Right.
Okay?
Yeah.
So let's not pretend that COVID-19 isn't a big deal.
Yeah.
We do take the flu seriously. We shouldn't just say 30,000 people, will die, and because COVID-19 is this thing, certain amount of people are going to die anyway. It's not the same thing.
And I think Brian, that's a good point. The flu shot's not, unfortunately, is not 100% preventative of getting the flu. And
Sure.
certainly a percentage of those 30,000 people that may die annually of the flu didn't take some of those preventive measures that may have been able to help them. But I think the one thing that's just really, really different about this disease is the relative virulence, the ability to infect so many.
Yeah.
And then the order of magnitude, when you're talking tens of millions, that gets people thinking,
Yeah.
right? And the one thing about the flu that's quite different is when you get real influenza A or influenza B, you are knocked down.
Yeah.
And you just close your door, you get in the covers, you take Tylenol, ibuprofen, you drink water, you cannot eat food.
You're just hanging on.
You're just like, I'm trying to make it. And then your infectivity there is lower because you're down. The problem here is there's a fair amount of people that don't go down. They have minimal stuff, and that creates their normal patterns of stuff they do, and that creates opportunity to infect a lot of other people.
That's a great point and a perspective that I hadn't thought of till this
Yeah.
conversation. I
Yeah.
mean, that really does. I mean, when you're sick with the flu, you can't go anywhere.
Yeah,
you don't want to go
You
anywhere.
just can't, you don't even think about it. You're just
Right.
trying to get till 3 or 4 days down the road when this passes,
just
right?
let me crawl out of
Yeah.
this at some point.
Right.
And this is not how people, that's the challenge with this particular
You're not
type
going
of
to
virus.
Disney World with the flu, right?
Yeah, exactly.
You're not doing that.
Yeah, you're not going to South by Southwest,
Yeah,
or
right, yeah.
you're not transmitting or getting on a pleasure trip to on Delta somewhere.
Yeah,
It's a different thing, and you can with COVID-19. That's what makes it so dangerous. Well, I got a little fired up there, but
No worries.
I'd like to pivot to something personal, because
Sure.
we did know each other for a while, and we did a photo shoot here in my studio a while back. But we had talked about my daughter who has type 1 diabetes, and you turned us on to the endocrinology unit there.
Yep.
And through that conversation, you told me you were sharing about your wife has had some very serious ailments in terms of her own endocrinology and that type of thing. And you referred me to her specialist who's at Metro Health, and
Yep.
you're like, this is who my wife goes to.
Yep.
She could go anywhere in the country to see
Yeah.
anybody, but
Yeah.
this is the dude.
Yeah.
And now my daughter sees him. But how does it shape when you have somebody in your family who has some, you're not just a health administrator, you're a husband and
Yeah.
a father,
Yeah.
but how has that created empathy in your own life in terms of how you care for patients?
Well, everything that I'm doing today, I really think about is to make things better for her.
Yeah.
And I think when you're, as a physician who's a patient, or a physician who's a husband of a patient, that's a very uncomfortable journey. We know, as good as the healthcare system is, there's always opportunities to be better. We do know in the United States of America that the third leading cause of death is medical errors, right? And those happen in environments like hospitals or ICUs and things of that nature. So it's a very uncomfortable journey. I mean, I'll just kind of relate at a high level. Our healthcare journey with some of her endocrine issues started back in 2018. She developed something called the pituitary macroadenoma. She had a pretty involved surgery, brain surgery, to get that resected and addressed, and thankfully everything is okay there. Several months after that surgery, she went and saw her endocrinologist, who was sitting across the exam room, and I wasn't there for this visit. This happened in Portland, Oregon, where we used to live, and the endocrinologist said, "Hey, can you swallow? I think I'm seeing something in your neck, like a little lump in your neck." And so my wife was like, "Oh, sure," and then put her on the exam table, felt that thyroid, felt that it was abnormal, felt like she felt a nodule. So then we got referred. This was now after the brain surgery, 3 or 4 months after the brain surgery for the pituitary issue. Now there's this thyroid issue that's out there. And so, got a biopsy of that nodule. It came back as something called papillary adenocarcinoma of the thyroid. The good news with that cancer, if there's any good news, is that it tends to be indolent, tends to grow very slowly for the majority. Although at the time my wife was in her early 40s. And so then that meant another surgery, and there were several different options. I'm not going to get into all those details, but the right choice for her was to completely remove the thyroid, and that's what was done. And she's, knock on wood, has had a good result. This was all back in 2018. When we moved out here to West Michigan and Grand Rapids, We hooked her up with a couple of people that are in my group at Metro Health. She's had great care at Metro Health, wouldn't change anything about it. But one of the things that we wanted to seek some answers to was, she's quite young to have these multiple endocrine issues, someone in their early 40s when diagnosed with some of this stuff. And so, Metro's not far from a world-renowned organization called the Mayo Clinic. And just actually as this sort of pandemic was starting to shift around in America, earlier this month, which was March of 2020, we went there and saw some of those specialists, kind of were able to squeak in before things really got kind of tighter. So we had her see, people in the endocrine group, the thyroid group, the genetics group. She also has high blood pressure, so we went to the hypertension group, women's health, a few other spots. We want some, answers around what are the implications for our children? We have 3 children. 2 boys and a little girl the boys are teenagers. My daughter's 9. And so we wanted to know what, if any, implications there might be for them. And so that was one of the main drivers of wanting to seek out that place. And I can say a lot of comfort came from the care that she received, the validation that everything that she had at wherever she had it was on track in the Mayo experience, right?
Yeah.
And that there was opportunity to potentially draw some blood and bank it for genetic testing.
Yeah.
It's not.
Well, that's the field that they really shine too, is that sort of specialized finding genetic factors in things. We tend to, with 2 of my daughters, we've been frequent flyers for different reasons for things, but we had umbilical cord stuff tested to find why my youngest daughter had a hemorrhage in utero, brain hemorrhage.
Right.
So, the went off there, and so that's a center of excellence for a lot of things. But that genetic factor that you're searching for, because you're projecting through the health of your next generation and kids, and wondering how you can plan, but certainly as someone who's a leader in a healthcare organization, a large one, having a big impact, when you're so immersed in the care of your own family, it has to bring some other perspective to how you're projecting the future and how you want to drive excellence through your organization?
Yeah. So just a little perspective, we do about almost 550,000 visits annually at Metro Health. These are those face-to-face visits that I was talking about earlier. And, my role today is really focused on how do we make sure that those people get the best care consistently all the time, and that my role as the leader of the group is to really make sure that we're bringing in the best physician talent we can possibly source that our primary care physicians can refer to. Because I think presenting awesome specialist solutions to primary care physicians is a big part of my job, right? And in some areas we may not be as strong as we need to be, and I will fight to make sure that we have great solutions across all the areas that we're choosing to focus on. I think of that as one of my main roles, is making sure that if you join our group that we're going to get high quality people for you to refer.
Given the unique challenges of COVID-19 and the dramatic stresses just in planning for this potential surge, and how you've modified and are planning for the future, I mean, what are the longer term impacts that you see on the healthcare system? Are there rays of hope in terms of how it might impact everybody positively?
Yeah, no, there's with any kind of crisis, you have to stop, pause, and think there might be some silver lining with this, right? Otherwise, why do we have to go through it? Right? So I tend to take that spin, and I would say from a healthcare vantage point, I think we're going to learn a lot of things from this. I think I'm going to call it digital health, virtual health, the ability to see a physician through a FaceTime type interaction. I think that's going to accelerate dramatically. And I think we're going to learn in these next quarter or two, like how much we can deliver to patients in the privacy of their own home, in the privacy of the physician's home, right? That's going to really accelerate. And I think there's been a lot of rules and regulation, mostly driven by the government, the Centers for Medicare Services. that had a lot of rigid rules around virtual health, let's say, and I think they've relaxed a lot of that because of the crisis. They've been like, hey, you can do a Skype call, you can do a FaceTime call,
Sure.
you can do so. That was not allowed 10 days ago.
Yeah, right.
So I think with this, relaxing on some of the regulatory components of how to give this care, we're now like, it's opened up like this innovation. So I think this crisis is really breeds innovation. I think the crisis helps melt away the hand-holding change management stuff that we have to sometimes do.
Sure.
I think we're really trying to present our best selves to the patients. We're really trying to be there for the patients because they find comfort with that.
Yeah.
Like, hey, I'm having issues with my blood pressure. I'm going to be able to talk to Dr. Pai on the
Yeah.
FaceTime call. I think we need to create that normalcy for them.
Sure.
Because as you said, there's so many people that aren't going to get this and still have their normal ailments, right?
Right.
So I think that's one thing. I think two is healthcare's been a laggard in this work from home best practice, right? Thinking that if you're working from home, you're goofing off, or you're working from home, you're not productive, or if you're working from home, you're playing on the internet. I don't know what we think, but
Yeah.
but I
Right.
think we know even in the healthcare environment, there's a lot of things people do that works. It could work from home. Like we
Yeah.
have these people called social worker care managers or nursing care managers. Think of them as air traffic controllers trying to help patients get from
Sure.
out of the hospital back to the clinic, and they might work with a home health agency. They might work with a behavioral health person too. And I think a lot of that can be virtual. Right now
Sure.
it's telephonic, so why can't it be
Yeah.
virtual with the video? I think so. We're going to get better about working from home for certain types of jobs.
Yeah.
There's
Well,
an,
I think that impacts not just healthcare,
Yeah,
but that's
absolutely.
everybody right now is working remotely. I'd listened to a fascinating podcast with the founder of WordPress.
Yeah.
And the WordPress, that guy's sort of thinking about how, and that was on Sam Harris's podcast.
Yeah.
And it was fascinating to think about how this crisis right now around COVID-19 is accelerating the normalcy of this remote, call it tele or digital conference or whatever, or working from there. This is a fundamental shift. I don't think that's going away. I think a large percentage or a substantial percentage of people are going to continue to work from home more, maybe not exclusively, but the capability is there.
I absolutely see that across multiple and different industries. And then I think the last two things that I've sort of noticed, I think it's the prioritization of others that I think we're a little more conscious about that. Like, I don't want my parents to get it.
Sure.
You don't want your
Yeah.
parents to get it. They're probably older and they probably have some conditions.
Yeah, it's my mom's 80th birthday.
Yeah.
today.
Okay. So
today.
Yeah. So well, happy birthday, Brian's mom. But it's just sort of like this disease in that population. I know younger people can get more severe cases as well and need a ventilator and things. But I'm really thinking about that population because some countries have had to make some tough calls about how to treat those types of
Yeah.
patients, and we don't want to do that here. So I think prioritizing others, thinking about others, and then I think the last piece is that I found is this social connection with your unit, like your family unit.
Yeah.
Like I'm spending more time talking to my kids than I thought maybe when they're at school or, it just, I don't know. That's one thing I've noticed about ourselves. We're talking, we're interacting, we're, laying on the bed together.
Yeah.
I don't know, doing stuff like that.
Yeah. Some of the coolest things that have come out of the last couple of weeks is just, I have a 20 and a 18-year-old.
Yeah.
And just watching TikToks with them
Yeah.
and just laughing like crazy. The amount of laughter that we've had, gut busting,
Yeah.
is in a normal flow of life.
Yeah.
You don't get those moments as often. So. Yeah, that whole human side of empathy and just really sort of taking in how precious our health is, what a razor's edge it is to be healthy. Any moment we can be inflicted with something that
Yeah, we need to value that
Yeah.
and don't take it for granted because it can slip.
Well, the other thing, and I just that idea of I think if we can create systems and solutions, I think is a better word. If you can create solutions that care for the most vulnerable in society, whether it's the elderly right now, it actually flows up to all of us. So if you're trying to spare an elderly person from getting infected, you're actually helping yourself. So you might not need it today. You might not be sick today. You might be able, through just caring about one other person or family member or a neighbor.
Well, Brian, I hope to be elderly someday. So I hope people that are in my age bracket today would be thinking about me when it's my time to be in that bracket, right?
Yeah. Well, one thing I noticed during this conversation is I've touched my face 500,000 times during that, and you haven't touched your face once. So kudos on you for that.
If it's very intentional, it's hard to do
Hard,
that.
but
Yeah.
anyway, I've noticed I'm this guy. I'm listening, But anyway, I really appreciate your time, especially during this particular pressure on our community and our health care system, that you would come in and have such a detailed conversation about what's happening at Metro Health, and just from your expertise, it's been wonderful to learn from you. And I appreciate it, and I hopefully we'll be old together.
Yeah, absolutely. Yeah, absolutely. No,
Very
Brian,
much.
I'd say thank you. I really appreciated the engagement, the opportunity to talk to the viewers. We're going to get through this. It's going to require sacrifice from everybody, but we're going to be better from this.
This Full Exposure podcast episode has been made possible through the support of Metro Health, University of Michigan Health, and Dr. Peter Hahn, who believe that creativity and the arts are essential to a rich, healthy, and fulfilling life.